Hello everyone, and welcome to a discussion on disorders of the neuromuscular junction. This is the neurology module as part of the Step 2 CK for the USMLE, but it's pretty good for clinical modules for any country at any university. So we're going to talk firstly about myasthenia gravis. This is obviously a main disease that we compare to Lambert-Eaton syndrome. So we're going to discuss those two disorders, and then we'll finish by talking a little bit about Botox and botulism. So myasthenia gravis is an autoimmune neuromuscular junction disorder caused by nicotinic acetylcholine receptor autoantibodies. These autoantibodies bind to the nicotinic acetylcholine receptors on the postsynaptic neuromuscular membrane, and that's going to result in a fatiguing muscular weakness syndrome with a sex-specific age distribution. What does that mean? That means that it does affect women and men. In women, it's usually seen in younger ages, such as 20 to 30, and in men, it's usually seen in those older ages, 60 to 80. Okay? 75% of patients who have myasthenia gravis also have an underlying thymic disease, okay? 85% of those patients with the thymic disease will have thymic hyperplasia, and 50% of them will have a thymoma. And that's really important when we discuss the management of patients with myasthenia gravis. Often includes a CT of the chest or an MRI of the chest to look for an underlying thymic disease. So just before we go on to the sort of presenting complaint and the history of the patient, I just want to briefly describe exactly the pathophysiology of it. So for example, say we have the motor end plate. This will be connected to the muscle on the sarcolemma. And let's just say we have a synapse here connecting and leading onto the motor end plate. The synapse will be releasing acetylcholine over the synaptic cleft to bind to acetylcholine receptors on the motor end plate, and that will then cause depolarization, and that will then cause a muscle contraction. Okay, and in myasthenia gravis we have autoantibodies that will be binding to these acetylcholine receptors, and these will outcompete, or will at least compete, with acetylcholine. And one of the key terms that we mentioned in myasthenia gravis was this idea of a fatiguing muscular weakness. What does this mean? This means that when I'm using the muscle, the weakness gets worse. Okay, so it's worsening weakness with movement. So the reason why is because as I am trying to contract this muscle, I'm going to be creating lots of depolarizations of the axon and the synapse. So eventually I'm going to be using up all the acetylcholine in the synapse. And eventually when I've run out of that acetylcholine, I will have worsening weakness. Okay? So just putting that aside, these are two CT images showing a thymoma, specifically in a 61-year-old female who was just about to undergo a surgical resection. So, what's the history and physical examination of patients with myasthenia gravis? The hallmark is muscle fatigability. Okay, small, often used muscles like the eyelid or the jaw muscles are more sensitive to acetylcholine receptor antibody interference, which results in ocular symptoms, most commonly ptosis and diplopia, facial weakness, bulbar symptoms. If you recall, bulbar symptoms are referring to the muscles around the face and the neck. These are usually cranial nerve-based muscles. So this could be presenting as difficulty chewing, dysphagia, dysarthria, and also patients have an upper and lower extremity muscle weakness, notably worse at the end of the day and with sustained activity. So a typical presenting complaint of somebody with myasthenia gravis is a patient has muscle weakness, and this includes a ptosis, often at the end of the day, or when they're eating food. They often have dysphagia and difficulty chewing because they're going to be using those muscles, so those muscles are getting fatigued. And maybe they have weakness in the arms or weakness in the legs at the end of the day, or when they play football, for example. Okay. Another really important distinguishing feature of myasthenia gravis is the absence of autonomic symptoms. It's the only neuromuscular junction disorder that will actually have no autonomic nervous system symptoms. So we're going to have normal pupillary response, normal sensations as well, and deep tendon reflexes are unaffected, okay? And of course, progressive muscle weakness occurring with increased use, that whole idea of fatigability of the muscles. I'm going to talk about myasthenia gravis versus Lambert-Eaton together when we've finished talking about Lambert-Eaton syndrome. When we discuss myasthenia gravis, it's incredibly important to discuss the myasthenic crisis. So the myasthenic crisis is a rapid worsening of muscle weakness that is life-threatening. And the reason why it's life-threatening is because it's often involving respiratory distress and airway obstruction. This is because it's usually involving the diaphragm, the respiratory muscles, and also the bulbar muscles as well. Precipitating factors are usually things like an infection, surgery, and drugs. And the drugs that you should look out for in a question stem are your aminoglycosides and your fluoroquinolones from the antibiotics, hydroxychloroquine, and also beta blockers as well. And this is actually a reason why people with myasthenia gravis, they should avoid those specific drugs, okay? But usually in a question stem, it's going to be a patient who's recently recovered from an infection or recently had a surgery, but do look out for those medications, okay? So, how do we diagnose myasthenia gravis? So, the best initial test, given that you suspect myasthenia gravis, is going to be your acetylcholine receptor autoantibodies. If this test is negative, but you really suspect myasthenia gravis, you're going to call for the muscle-specific kinase autoantibody, okay? It's not as often seen. The acetylcholine receptor autoantibodies are more commonly positive, but this is another way that we can diagnose this disease without the acetylcholine receptor autoantibody. The most accurate test is actually the electromyography, and this is going to be proving our famous fatigability of the muscle, okay? So what I'm going to be doing is I'm going to be doing repetitive nerve stimulation, and then I'm going to be measuring the muscle contraction. And as I'm doing repetitive nerve stimulation, I'm going to see a decremental response in that muscle contraction. That means I'm going to be seeing decreasing muscle contractibility with repetitive nerve stimulation. This occurs and the reason why is because I've explained it already when we talked about the pathophysiology. Endogenous acetylcholine stores are depleted, and the acetylcholine receptor antibodies will outcompete the endogenous acetylcholine for nicotinic receptors. Imaging, as I mentioned before, must be done, and we're going to go with our contrast CT and MRI. This is just to check for thymic disease, okay? And they love questions in the USMLE about knowing that we have to do that imaging. There are two different bedside tests that we can do for myasthenia gravis. They're both very simple, and they're actually not so commonly done in most clinical settings, but it's just good practice to know that these can be done. We can apply ice for 1 to 2 minutes on the eyelid, and that should relieve the ptosis in patients with myasthenia gravis. And the reason why is very simply due to enzyme kinetics. If I increase the temperature of enzymes, the rate of reaction goes up because my enzymes will be binding more to substrate. So if I decrease the temperature by applying ice, acetylcholine esterase's activity will decrease because of the kinetic energy decreasing. And that means that less acetylcholine esterase will be degrading acetylcholine. So therefore, I have more acetylcholine in the cleft. We can also do a bit of edrophonium as well. We can talk about the role of edrophonium in the treatment as well. But this is an acetylcholine esterase antagonist, and that is going to do exactly the same thing as applying ice. That is going to raise the endogenous acetylcholine in the synapse, which is going to improve motor symptoms. So both of these tests are kind of playing on that idea that I'm going to be decreasing acetylcholine esterase, and that is going to improve symptoms for a short period of time. One thing that is quite important to know is the acetylcholinesterase toxicity. And I'm going to go through this in a minute because this relates to the treatment. When we give acetylcholinesterase antagonists or inhibitors to patients with myasthenia gravis, it's quite an important scenario that you need to be able to see if they've got toxicity of those drugs, but we'll talk about that in a minute. Just a quick key fact, myasthenia gravis presents with eye and bulbar muscle symptoms that worsen with use. Initially, normal reflexes that worsen with testing. They have no autonomic dysfunction, and it's very commonly associated with an anterior mass, i.e. thymic hyperplasia or thymoma. So that's just summarising what we've discussed already. So let's talk about the treatment now. The treatment is going to be involving two different sort of schools of thought. I've got to treat the myasthenic crisis, that's a separate treatment, and then we can also talk about the chronic management of a patient with myasthenia gravis. So let's talk about myasthenia crisis treatment. What I've got to do is I've got to do plasmapheresis or intravenous immunoglobulin, and I can also give steroids as well. The plasmapheresis is just going to remove those antibodies, and then I can alternatively just give immunosuppressive therapy. I've got to be monitoring the vital capacity, maximum inspiratory pressure and airway patency, because I need to know whether this patient is going to require ventilation, whether that be invasive or not invasive. If you recall, when we talked about myasthenia crisis, we mentioned that these patients are at risk from respiratory distress. So if I see any indication that the maximum inspiratory pressure is decreasing or the vital capacity is decreasing, then this patient is going to be indicated to have some form of ventilation. So let's talk now about chronic drug therapies. We have our acetylcholinesterase inhibitors. These are always going to be the best initial treatment. We're usually looking at pyridostigmine. And with that, I can give something called glycopyrrolate. This is an anti-muscarinic drug to control the autonomic side effects of my pyridostigmine. Okay? Most patients will also need immunotherapy initially as well. We start with steroids, and then we can transition to non-steroidal immunosuppressants, such as azathioprine, because we don't want to be giving steroids for a long period of time. So we usually start with steroids to sort of induce a remission, and then we go on to azathioprine as well. So now I'm going to come on to the anticholinesterase drug toxicity. Okay, so this is a toxidrome that these patients can get. Because people with myasthenia gravis, they lack those autonomic symptoms, we need to watch out for any of these patients that start to get autonomic nervous system problems, such as the cholinergic activation. Because a patient with myasthenia gravis is not getting any of those autonomic symptoms, if all of a sudden the patient starts to get cholinergic toxidrome signs, I've got to be thinking this is due to their medications, not to the disease. So let's have a little scroll up back here so we can see the side effects of the anticholinesterase toxicity. So it could include diarrhea, increased urination, miosis of the eyes, the 3 Bs of bradycardia, bronchoria, and bronchospasms. The patient will be vomiting, so emesis, lacrimation, lethargy, and salivation. Okay, so if you start to see a patient who's got myasthenia gravis, is taking pyridostigmine, and they start to get some of these signs, then you can be assured that this is the anticholinesterase toxicity. And finally, last but not least, surgery. A thymectomy is indicated in all patients with thymomas. Every single patient with a thymoma, they're going to get a thymectomy. But it's also indicated for all patients less than 60 years of age with a mild to moderate disease. So say you have a patient less than 60 years old, they have a thymic hyperplasia, their disease is not too bad, it's well maintained, they would also be indicated for surgery as well. Because if you think about it, surgery is a risk factor for myasthenic crisis. Only patients who kind of fit the good prognostic scale would be allowed to have a surgery if they didn't have a thymoma. Right, now we can move on to our Lambert-Eaton myasthenic syndrome. So this is also called LEMS. It's an autoimmune neuromuscular junction disorder caused by antibodies against the voltage-gated calcium channel. These autoantibodies bind to the voltage-gated calcium channel on the presynaptic neuromuscular membrane and other presynaptic terminals located in the autonomic nervous system as well. And that's going to decrease acetylcholine release from that presynaptic knob. This results in muscle weakness syndrome with autonomic dysfunction. It can occur as a non-paraneoplastic syndrome or a paraneoplastic syndrome. This means it can occur as a result of a cancer, or it can occur outside of patients who have cancers. But it is most commonly seen in cancers, and it's most commonly seen with patients who have small cell lung cancer, and that's very high yield to remember. Just a key fact, this is one of the most important things to remember for these two syndromes. Repetitive nerve stimulation reveals a characteristic incremental response for Lambert-Eaton syndrome. This essentially means that patients with Lambert-Eaton, their muscle weakness will improve with muscle use. Okay, and that is contrasted to myasthenia gravis, which has a decremental response that we mentioned. Yeah, the weakness gets worse with muscle usage. Just before we talk about the history and the physical examination, I just want to quickly discuss the pathophysiology in very sort of brief detail. So let's say this is the presynaptic knob, and then we have our motor end plate. We've already mentioned that myasthenia gravis acts here, okay? But Lambert-Eaton syndrome instead works on the calcium channel here, okay? So usually in synapse physiology, when an action potential runs down the synapse, that causes these voltage-gated calcium channels to open. Calcium will flood into the synapse, and that will assist acetylcholine vesicles to go across the cleft and diffuse across the cleft and cause a muscle contraction. Lambert-Eaton syndrome is essentially where we have antibodies that will be binding and blocking these calcium channels. So increased action potentials can overcome this blockage and can open more calcium channels, and that's why we see the incremental response when we use the muscles more, because we get more action potentials opening more calcium channels to overcome those antibodies. Okay, so just with that in mind, let's talk about the physical examination in the history. So the hallmark is muscle usability. Okay, that means that the muscle weakness is going to get better with muscle use. Lambert-Eaton syndrome is characterized by slow onset of proximal muscle weakness, difficulty rising from a chair, difficulty walking, maybe difficulty combing the hair, reaching upward to shelves. And obviously a big differential diagnosis will be myositis, okay, because that has that proximal muscle weakness as well. But all we've got to do is measure creatine kinase, and that's going to be normal in Lambert-Eaton syndrome. And yeah, also myositis, they usually have myalgia as well, pain in the muscles, which patients with Lambert-Eaton will not. The symptoms of Lambert-Eaton syndrome improve with activity, as repeated depolarizations of presynaptic terminals help overcome the autoantibody blockade of those presynaptic voltage-gated calcium channels, which I've just explained. Some other distinguishing features of Lambert-Eaton syndrome is the presence of autonomic dysfunction. Okay, autoantibodies bind to the presynaptic voltage-gated calcium channels and impair acetylcholine release in neuromuscular junctions throughout the nervous system, including the autonomic nervous system as well. This results in autonomic dysfunction, and that can include xerostomia, erectile dysfunction, constipation, impaired pupillary light reflex, just to name a few. Initial deep tendon reflexes will be low, but as I continue to elicit those reflexes, it's going to increase. okay? And that's the muscle usability phenomena. So let's talk about diagnosis now. The best initial test is checking for the antibodies, okay? The anti-voltage gated channel antibodies. And that's exactly the same as myasthenia gravis. We said the first best initial test we should do is check for the antibodies. The most accurate test, same as myasthenia gravis, the electromyography, okay? This is going to be showing the usability of the muscles with the incremental response to repetitive nerve stimulation. So I'm going to be stimulating the nerves, and the EMG will be showing increased muscle contraction as I'm stimulating those nerves. The complete opposite to myasthenia gravis. And then the best initial imaging test is a CT or an MRI again, but this time I'm not looking for a thymoma or thymic hyperplasia, I'm looking for a lung cancer, specifically the small cell lung cancer. So what's the treatment? If the patient has got an underlying cancer and it's a paraneoplastic Lambert-Eaton syndrome, then I need to treat the underlying malignancy. That's the single most important thing that I can do there. Aside from treating the underlying malignancy, which will most of the time be the correct answer in a question, I can also give amifampridine, okay, or guanidine. And both of these are going to be decreasing potassium efflux, and that's just going to cause more of a depolarization, and that's going to try and increase the acetylcholine release. Acetylcholinesterase inhibitors like pyridostigmine can also be used as well, but these are more seen as a treatment for myasthenia gravis. IV immunoglobulin followed by oral immunosuppressive agents, if persistent. Apologies for that. If persistent disease, despite medical therapy and treatment of the underlying malignancy. So if you've treated the underlying cancer, if you've tried giving the guanidine or amifampridine, then if it still doesn't work, we can then move on to the IV immunoglobulin and oral immunosuppressants. These are seen as being almost a last line for Lambert-Eaton syndrome. So just a final key fact is that Lambert-Eaton myasthenic syndrome presents with proximal muscle weakness that briefly improves with use, initially diminished or absent reflexes that improve with testing with autonomic dysfunction, okay? Classically in patients with a lung mass on imaging. So, just because we've now covered both Lambert-Eaton and myasthenia gravis, I want to just go back to that table that kind of contrasts the differences. So, we'll start with myasthenia gravis. This is due to an antibody against the acetylcholine receptor, and that's on the postsynaptic membrane, it's on the motor end plate. When we use the muscles, this will worsen symptoms, the muscle fatigability. As we test deep tendon reflexes, initially they may be normal, and they're going to get worse with repeated testing. Eye symptoms are very common, ptosis and diplopia at the end of the day, and autonomic dysfunction is absent. In contrast, Lambert-Eaton syndrome is due to the voltage-gated calcium channel autoantibodies on the presynaptic synapse, okay? And we do see this in the neuromuscular junction, but also in the autonomic nervous system as well. Using muscles will temporarily improve symptoms, we've discussed this before, and testing of deep tendon reflexes, maybe at first they're going to be absent or diminished, and they're going to improve with testing. Eye symptoms, not so common, but autonomic dysfunction, 100% present. So, to finish this module, I'm now going to be discussing Botox, okay, and botulinum. So botulism is a disease, okay, and it is characterized by symmetrical descending paralysis, and it's caused by ingestion of Clostridium botulinum spores, or it can be due to exposure to like soil or spores within the soil in endemic regions, but most of the time it's due to ingestion. We will discuss this more in the microbiology unit, but if somebody does have botulism, we're going to be giving them IV botulism immunoglobulin, okay, to bind to the toxin and prevent the toxin from acting on the synapse. And we're also going to provide respiratory support. Consider in any infant with bulbar palsies, ptosis, constipation, or hypotonia. And we should also avoid honey in young infants. Just more of as a step one kind of theory, but infants have got a very poor gut flora, okay? Their gut flora is not like adults. So honey usually contains a lot of the bacteria, okay? Not the preformed toxin so much, but the bacteria. And when they come into our system, we can easily outcompete these bacteria. But when an infant ingests this bacteria, they can't outcompete them. So the Clostridium botulinum will lay dormant in the GI tract, and it will release toxins into the systemic circulation. So adults can only get botulism from ingesting the toxins, the preformed toxins, but infants can get it from ingesting preformed toxins, but also from ingesting the spores with the bacteria in as well. And that's why you and I, who are adults most likely, can avoid honey, but an infant can have honey, but an infant should avoid honey. I'm just going to briefly talk about the types of botulism. So we have got the foodborne. This is, as I've said already, for an adult at least, ingestion of the preformed toxins. The incubation is usually around 1 to 2 days. The treatment is botulinum antitoxin, just an antibody that's going to be binding to the toxin to prevent it from working on the synapse. And how do we prevent it? Sterilizing food to sort of kill off those preformed toxins, and even boil food twice before canning, okay? Generally, the toxins that we find, the botulism toxins, they're usually found in canned foods a lot of the time. Infants, as I've said already, they can ingest the spores, usually in honey. The incubation period is going to be a lot longer because the spores need to germinate and they need to allow for the toxins to be produced and then released into the systemic circulation. The treatment will be human botulism immunoglobulin rather than equine antitoxin. And how do we prevent? Avoid giving honey to infants less than 1 year old. And then finally, we do have the so-called wound botulism, and this is where the spores, usually from either IVDU or from getting soil contaminated with the spores into your wound. The incubation is usually between 4 days to 14 days, and we can again give the antitoxin exactly the same as foodborne, and we can consider surgical debridement as well. Obviously, avoiding IVDU is going to help, and we should be doing normal wound care as well. So that completes my discussion on the neuromuscular junction disorders. Please stay around for the other neurological chapters. I hope